Welcome to the Jerry Pal podcast. This is Eric Widera.
This is Alex Smith.
And Alex, we have a guest in our studio audience today.
We have a guest in the studio in Eric's office. Sometime we're going to have to tweet out a picture of this. It's quite comical. But today we have Brian Block, who is a pulmonary critical care fellow here at UCSF. Welcome to the Jerry Pal podcast, Brian.
Thanks for having me join you guys.
And we have a guest who's joining us from the University of Pittsburgh. And it's Doug White, who is professor of critical care medicine at the University of Pittsburgh and just published a study in New England Journal of Medicine that we're going to talk about.
I heard about that journal.
You heard of that one?
Yeah, it's a good one.
Journal of this small medical society in some northeastern state, minor journal. Welcome to the Jerry Pal podcast, Doug.
Thank you very much for having me.
So before we dive into the topic, this New England Journal paper, we always ask our guests, give a song request for Alex. Doug, do you have a song request?
I do, yeah. Gillian Welch, Look at Miss Ohio, which is, I think, a beautiful song and also just a little bit subversive in the roles we sometimes feel pressured to playing in life.
Great.
Good? All right, I'm going to play it.
Oh my, oh, look at Miss Ohio. She's running around with a rag top down. She says, I wanna do right, but not right now. Gonna drive to Atlanta and live out this fantasy, running around with a rag top down. Yeah, I wanna do right, but not right now.
Awesome.
Nice. I'd love to see Gillian Welch in concert. She's such a great musician. The Appalachian folk sort of rocky thing going.
Absolutely. Alex, that was fantastic. Nice work.
Thank you, Doug.
Before we jump into this New England Journal of Medicine paper, a randomized trial of family support intervention in ICUs that just came out this last week, maybe you can take us back a little bit and just tell us how you got interested in this subject.
Yeah, well, so, I practice in intensive care units at the University of Pittsburgh, and for part of the time, and the rest of the time I'm doing research. And the issue of seeing families overwhelmed and really struggling with making decisions for critically ill patients has always been something that I have thought we could do better, and we really haven't brought to it a critical lens of let's think about a careful system that's theoretically grounded, and let's give it a whirl. Let's see what we can do. So it really came out of my clinical experience.
So let's start talking about the study. Just dive right in here. Tell us, sort of briefly, high-level overview of what you did here.
Yeah, so this was what's called a stepped wedge randomized trial.
A what?
Stepped wedge? Is that a podiatry,
stepped
like
wedge.
some type of
know.
shoe that you wear?
It is clunky, but it's not a shoe. It's essentially a method where you randomize ICUs to the time at which they get the intervention. So every ICU starts in the usual care phase, and then at random time points they transition to the intervention phase. And the reason we chose this method is that as you'll hear, the family support intervention we tested is really an ICU level intervention. And if we had tried to randomize individual patients, the care that the control arm got would have been contaminated. So, stepped wedge trial, we randomized 1,420 patients and their families to either the usual care arm or what we call the partner family support intervention. And we followed them both through the hospitalization, and then we followed surrogates to 6 months out. And the primary outcome of the trial was surrogates' psychological distress measured using the HAD scale, the Hospital Anxiety and Depression Scale. And then we looked at several pre-specified secondary outcome measures, including the surrogates' perceptions of the patient-centeredness of care, the surrogates' ratings of the quality of communication, and then a variety of measures of healthcare utilization like costs and ICU and hospital length of stay.
Great. That's a terrific overview. Let's dive in a little bit deeper into who exactly you studied, because these weren't just any patients in the ICU. You had specific criteria for who could get into this study.
That's right. So these were, for lack of a better term, kind of the sickest of the sick. The clinicians, we asked the clinicians to identify patients who they said had either at least a 40% chance of death in the hospital or a 40% chance of severe long-term functional impairment. Or the third criterion was that they had been on mechanical ventilation for at least 96 hours continuously.
Mm-hmm. All right. So this was a pretty sick population, as you say, and the mortality rate, in fact, was fairly high.
Yes, very sick population. 35% of the patients died during the primary hospitalization, and then by 6 months, 55% had died. And the other, I think, important thing about the population is that almost no one at 6 months was living independently at home. It was, I think, less than 2% in both arms.
Mm.
And Doug, this is Brian here. How about the people carrying out the intervention? Which members of the team, or were you bringing in other people external to the standard ICU team?
Yeah, let me tell you a little bit about what the partner intervention was. And essentially, what we set out to do with this intervention was take whatever resources are in the ICU and use only those resources to deploy the intervention. And so basically, we developed this interprofessional family support intervention as a way to sort of flip on its head how we typically support families, which in my experience in a variety of ICUs around the country is often somewhat ad hoc. It's the individual attending physician has his or her own personality, and that determines a lot of the family support that is delivered. And instead, we thought, let's make something more consistent, that it doesn't matter who the attending is that week. Let's develop a family support intervention that happens relatively regularly, regardless of who's there. And the second thing that's I think somewhat novel about it is that a lot of the work of family support in the intervention is delivered by existing ICU nurses who undergo advanced training. Mm-hmm. And so it's 4 to 6 nurses per ICU, go through 12 hours of communication skills training for the kind of things that we want them to be able to do in the intervention. And then they're there, and they're the ones who are interacting with the family on a daily basis, delivering what I think of as sort of both emotional support and practical support about what's happening in the ICU and how the patient's doing. And then the second thing these nurses do is they're responsible for making sure that family meetings happen at set intervals for the patient. So no later than within 48 hours of being enrolled, and then every 5 to 7 days thereafter. These partner nurses are arranging interdisciplinary family meetings that the attendings run.
So are these partner nurses the patient's existing bedside nurse, or is it an additional nurse beyond the bedside nurse?
They are, it varies. So it's not always the bedside nurse. At UPMC, there are charge nurses who are there every day who usually don't have heavy bedside responsibilities, and there are nurses called resource nurses who are there to help with education and ensure protocols are being followed for ICU care. And so it's these individuals. And sometimes it actually is that a partner nurse has a bedside assignment with another patient, and he or she makes the time during the day to go meet with the family that, for example, is going to have a meeting that day. So it takes a little bit of organization,
but no additional staffing requirements. This is
no additional staffing. That's
all
right.
under the ICU FTE.
That is right. That was sort of the thing that we said. Let's not bring in external people. Let's not add new people to the ICU team. Let's see what we can do with the existing resources that we just re-engineer the care processes around them.
So would you call this a combined effectiveness and implementation trial in some sense?
Yeah, this is, I think, substantially an implementation trial. We framed this as an intervention that is delivering recommended practices in terms of intensive emotional support and frequent family meetings. And the only thing that's different is that we wrapped it in a care delivery package that is more consistent than usual care is. So we both wanted to see, can we deploy the intervention, and then also what are the effects of the intervention once deployed.
So how did it deploy and what were the effects?
All right. So we trained these nurses, as I said, 12 hours of communication skills training with standardized patients and some pretty good communication skills training coaches here at UPMC. And then we had an implementation specialist, which many hospitals have, people who help deploy quality improvement interventions, helped each ICU develop care practices and protocols to make sure that the partner intervention was being deployed as prescribed or as directed. And so after a week of pretty intensive support, each ICU was kind of released to do the intervention, and with weekly site visits by the implementation specialist to see how things were going. And what we found was that the intervention on the primary outcome measure, on surrogates' long-term psychological distress, had no impact, really didn't change any markers on their symptoms of depression, anxiety, or PTSD.
So it's a negative study. So what's next for you, Doug? Given that you put all this hard work into this, probably
that's
many
the
years.
end of our podcast. And on to the song again. No, wait,
No?
There's more?
Well,
there's more.
So there is a little more. I would say there's a lot more, but I also think that a negative trial is super important. I think we learned a ton about this kind of intervention not moving the needle on surrogate psychological distress. And maybe we can come back to sort of unpacking why. But what was positive about the trial was every other outcome measure. So the measures of the patient-centeredness of care were much better in the intervention arm compared to the control arm. The measures of the quality of communication were much better. The length of stay was shorter in the intervention arm, substantially caused by decrease in the length of stay before death among the patients who died. And then the other thing that was substantially different were costs across arms. The partner intervention was associated with about a $6,000 decrease in costs per patient in total hospitalization costs.
And then was that largely just driven by length of stay or other factors?
It was substantially by length of stay, less use of things like blood transfusions, antibiotics, vasopressors, and then the costs of being in the ICU.
And it sounds like by not including additional staff beyond those normally in the ICU, you didn't incur extra costs for each patient?
Correct. So we did I should say we did a pretty careful costing of how much it cost to deploy the intervention. So we paid for the nurses' time to go through the training. We included the costs of the training, the meals and the rental of the facility and the actors. And we also included in our cost estimates all of the time and travel costs of this quality improvement specialist to go to the ICUs. And with all that, we found it cost about $170 per patient to deploy the intervention and got us about a $6,000 savings per patient.
Wow.
Now, just sticking on the cost for a moment, I noticed that the press officer for UPMC reached out to us about this study, and I noticed the press release is titled "Team Approach to Support Families Improves ICU Patient-Centered Care and Lowers Costs," and really leads with this cost finding in the first paragraph. And then there seemed to be a contrast between that story here and the way it was framed in New England Journal. I wonder if there's a story there about how the cost finding was emphasized in the press release and not as much in the scientific publication.
There's a bit of a story. I mean, I think you'll see in the New England piece the cost data are not included, with the exception of what it cost to deploy the intervention. So the cost savings were not in there. And that was an editorial decision on the part of the New England Journal. I think they really wanted to focus on the patient-centered aspects of this and not complicate the message with even more quantitative data about healthcare utilization.
So as a contrast, you've mentioned that this was a study that used just resources in the ICU, and comparing to a couple years ago, a study by Randy Curtis's group in the Blue Journal that looked at communication facilitators who were external to the normal ICU team. They actually did include some cost data with some similar findings in terms of shortening length of stay. I wonder if you could comment on why that made that into that article, but maybe not into yours.
Well, I would be speculating. I think to be clear, the length of stay data are included in the New England Journal paper. The only utilization data that weren't are the dollars. As I said, I think editors have a lot of discretion about the shape an article takes in terms of what's the right amount of data to put in it, what creates a compelling story, and then in contrast, what becomes too much to tell in one paper. And I think that was the decision they made and the piece of data they thought would best be dropped.
So I'm going to take a step back. So it was a tantalizing statement you said, how this is a negative primary outcomes study that made it in the New England Journal, and you learned a lot from it about surrogates, caregivers, family members, and the emotional burdens of the ICU. Do you want to take a little bit of a deeper dive on that?
Yeah. I think we have pretty clear data that the intervention substantially improved the surrogate's experience in the ICU. The ratings of the quality of communication were much higher. And these are, when you look at the individual items on the quality of communication scale, it's things like I felt that the doctors were giving me the information I needed to know. I felt like they were involving me in the ways I wanted to be involved. I felt like they were giving me emotional support and caring about my loved one as a person. So all of these things that we think are, really great, important things. And I think many of us, myself included, thought that if we only could improve this aspect of care, that might substantially lessen the trauma of the ICU experience in such a way that would modify their long-term psychological outcomes. And I think that assumption was just wrong. I think we really did modify their experience in the ICU and their sense of feeling supported, and that didn't change their long-term psychological outcomes.
Yeah, also brings up the issue of why were the long-term psychological outcomes the primary endpoint in a study that seems to be designed initially to, as far as my read, to improve communication and improve the emotional support for the caregivers of surrogates in the ICU, patients in the ICU.
Yeah, great point. In the design phase of the study, we thought a lot about should we even designate a primary outcome, and then because of sort of existing norms and the need to register one on clinicaltrials.gov, we picked the HADS as the primary outcome. But what I want to say, and the way we conceptualized the study and the outcome assessment from the start, is that there are three important domains of outcomes. There are the surrogate psychological outcomes that are certainly important in and of themselves, but separate from that, the experience of the experience and the patient-centeredness of care we viewed as its own separate important domain of outcomes. And then the third outcome of importance is healthcare utilization. And so when we conceptualized the paper and the project and when we wrote it, we said there are three primary domains of interest. And because of the psychometric properties of the HADS, because they're the best of all of the outcomes, we specified this as the primary outcome. Not because it was, in our view, the most important outcome to change.
So, Doug, I had the opportunity to see you present this paper last week at the American Thoracic Society conference. And one thing you emphasized there was that you did not use rational actor theory for your decision theory of this study, but instead used a cognitive emotional theory. Could you talk a little bit about that?
Yes, thank you. This is one of the things that I really loved about this intervention is that we, in contrast to the support intervention that was really about let's make sure we give people the right numbers and the right information and hopefully good decisions will logically flow from that. We abandoned that.
That's the rational actor?
That is in decision sciences, that's expected utility theory or the rational actor theory, that with good information, good decisions will follow. And there's been a great deal of work in decision sciences over the last couple decades that suggests that there are many things that get in the way of this theory that good information will lead to good decisions. And in our context, one of the most important considerations is the role of strong emotions like fear and anxiety. And really good decision scientists and experimental psychologists have documented how fear and anxiety change how people both are able to process information and also the decisions they make with that information. In what appear to be problematic ways. It tends to make people make really sort of snap judgments that are grounded in less deliberation than you might hope for such weighty decisions. And so we felt that not only do we need to make sure that surrogates are getting good information, we also need to deploy an intervention that substantially targets providing emotional support with the goal of moving these surrogates from what I think of as a hot state, emotionally overwhelmed, to a cooler state where their emotions are there, and I think it's inevitable that they will be there, but they are not overriding their ability to think clearly and to think about trade-offs.
So what would you recommend for those of us practicing in San Francisco where it's a rather temperate state?
I think cool is the right place to be. And I don't mean cold. I mean, I really don't. I think it would be a mistaken view of the intervention if someone walked away and said, well, they were just trying to do away with emotions and actually get people to a place where they could be purely rational. And that's just not what we were trying to do. And I don't think that's even a realistic goal. We were really trying to bring emotions and rationality together in ways that they can each bring out the best in the other. And so a lot of the work of emotions when we make decisions is to alert us to the salient features of a decision, right? The thing that sort of tugs at our heart sometimes is the thing that we most need to be thinking about.
That's well put. I wanted to ask you about the mortality finding. It seems that the mortality in the intervention group was 6.7 days and 7.4 days versus 7.4 days in the control group, and that difference was statistically significant. And yet mortality at 6 months was the same between both groups. So that, if I could, put this in other words, you might say that we weren't prolonging the dying for patients who are in the ICU who were going to die anyway. Does that sound like it's in line with what you would describe?
Yes, that is how I interpret the data also. I think it's really, really important that we collected data on families' perceptions of the patient-centeredness of care, because if we only had the finding the intervention led to more deaths or speedier deaths in the intervention arm, we would be left with this question of, gosh, is that good or bad? And the data that show that the intervention yielded more patient-centered care suggests to us that these are decisions that the family felt reflected the patient's values and preferences to not be kept on life support in the face of a poor prognosis.
So with all this data and this study coming out, like what's next with this? Is this something that all ICUs should be adopting, or is there a next phase, a partner version 2.0?
Well, so very good question. I'll answer it in two ways. One, I'll tell you what's happening at UPMC, and then two, I'll talk about what I think needs to happen from a research standpoint. So UPMC is a 25-ish hospital system, and they have made the decision to roll out the partner intervention across all the ICUs in the health system, and that has been ongoing for the last few months. So UPMC has decided that this intervention makes good sense and improves the care of patients and families, and we should go forward with it. I think that is reasonable. One other interesting thing about the editorial process in the New England Journal is the editors were very clear with us that we needed to include a statement in the discussion that said the results need to be confirmed in a larger pragmatic trial that involves multiple health systems in multiple regions of the country. So I guess that's sort of two ways to illustrate how two different groups viewed the implications of the trial.
So I got another question. What was Palliative Care's involvement in this? Do they no longer need to see ICU patients because you got these trained nurses there?
That's not how I view it. So I think in an ideal world, this intervention would be sort of what we think of and call generalist palliative care or primary palliative care delivered by an ICU team that is just a little bit more skilled and a little bit more coordinated than they were before the intervention. And I think that will most definitely not do away with our need for our palliative care colleagues to help us both in terms of managing higher level palliative care issues that arise, such as conflict between the clinicians and family or conflict within a family, or even attending to families who are highly emotionally distraught and the sort of the best basic interventions of the care team are just not moving it in the ways that we would hope to. So when I give talks on this, I liken it to a cardiology consult. So as an intensivist, I'm comfortable managing a variety of cardiac issues, straightforward AFib, A-flutter, VTAC, VFib. But there are some things that get complicated and where I really am not sure what the next thing to do is. And that's when I involve my palliative care colleagues or my cardiology consults in this circumstance. And that's how I hope people will view how to integrate primary palliative care and specialist palliative care.
So let me ask you another follow-up question to that. So a couple of years ago, you wrote an editorial on a JAMA paper about proactive family meetings for chronically critically ill patients. Some dub this proactive palliative care consults, although that's a whole nother podcast that we can talk about. How do you think about these two studies, your study and the last study around like communication in the ICU, the JAMA study on chronically critically ill patients?
Yeah. So I think it's really important to point out that as the distinction you made is the right one. That was not a palliative care, a full palliative care consult. That was prognostic information from a mortality prediction model delivered by palliative care clinicians to the family, presumably in a very sensitive way. But that's still a pretty cognitive intervention, right? That's one or two meetings where the interventionists in the SIT trial, their role was to make sure that they talked to the family about the patient's prognosis and then to think about the implications for goals of care decisions. And on its face, that's a wonderful thing to do, right? And if the rational actor theory was true, that should have been enough, but it wasn't. And I think that study also compelled a lot of us to think a little more critically about, what is it that needs to happen to help families make good decisions? And I think many of us are coming around to this idea that it's a lot about aligning with families and about establishing trusting relationships and in helping them move through tragic and really hard experiences, which typically isn't just done by laying out the bad news and hoping that will do all the work. And I do want to say the SIT investigators are fantastic investigators. I think they did a really nice job of answering a hugely important scientific question and in ways that really advance the field's thinking about what's going to be needed to move forward.
I agree. I love this study because it shows you the impact that a negative study can actually have. Like it teaches us a lot more than I think it would have taught us if it was a positive study.
Absolutely. I think if it had been a positive study, we all would have said, well, of course it's a positive study. That intervention makes perfect sense because at the time it did make perfect sense. And it was saying, let's bring in the heavy hitters, really skilled communicators, and just have them deliver this news and talk about goals of care and see how that goes. Mm-hmm. And I think we got a good answer to the question of is that enough? And I think the answer is it's probably not enough.
Mm-hmm. Any sense, this article's been out about a week now, is that right? And so any sense of the reaction from the community? I'm particularly interested in reaction from the nursing community. I mean, this is a nurse-led intervention. And to my mind, although it was, primary outcome was negative, it wasn't the outcome I actually cared about most. It was very positive in some ways. And so I'm curious what there's been uptake within the nursing community, enthusiasm, and also in the physician community. How are they responding? And perhaps a sense from, what kind of questions were people asking at the American Thoracic Society meeting last week when you presented these at the time the article was published?
So, yes, there was a lot of enthusiasm about really fully leveraging the interprofessional team and giving nurses the kind of responsibility that fits with their professional competence. I think the nurses in ICUs are incredibly skilled and in many circumstances not being used to their fullest. And that's both kind of unsatisfying for many nurses and also leaves them on the sidelines witnessing things that are quite distressing to them. So I think from the standpoint of the nursing community, the feedback I've gotten has been really quite enthusiastic about, we want this role and we think that this is the direction the field should go. The other interesting comments were people some of the emails were people saying, it's really great to see that the Kahneman and Tversky model is the model that we should be focusing on and thinking about rather than the rational actor model. So it's really interesting that people are sort of embracing this more modern view of what goes into good decisions and recognizing the hugely important role of affect in that.
So, Doug, you described this in parts in the manuscript as a quality improvement study where you're using guideline recommended interventions. What does it say about guidelines that some of the outcomes were positive and some were negative?
Well, these guidelines are the kind of guidelines that are from expert consensus largely. They're not based on high quality randomized controlled trials. And I think part of the goal of a trial like this, which is, as you said, is a hybrid implementation effectiveness design, is to actually provide some empirical evidence about whether our guidelines are the right ones. So I think it's both appropriate to have framed this as a quality improvement project because we were basing it on the best available professional society statements about how families should be supported. And, I think it does raise interesting questions about what should be the next steps.
Well, Doug, I really want to thank you for your time with us, and thanks for going over your article, and really great work. I love this study.
Thank you. This is terrific, Doug. You should be so proud of what you've done here. And to publish in New England Journal just gives it this enormous mouthpiece. We will try to add to that in our own tiny way with our Jerry Pal podcast.
It's almost as much of an honor as being on the Jerry Pal podcast.
Almost.
This has been great fun for me. I really thank you guys. Your questions were fantastic. It was really fun to look into it. Can I just say also that I think the trial was the culmination of lots of people's efforts, and so I'm glad to have gotten to be the one to be in the first author position and write it up, but it really took lots of nurses and docs in these ICUs agreeing to do this work and sort of experimenting with how can we improve things for families. And so I want to acknowledge everyone who was involved in it too.
Great, and great work again to everybody. How about before we end, Alex, do you want to give us a little bit more of that song?
A little bit more Gillian Welch here. Had your arm around her shoulder, a regimental soldier, and mama starts pushing that wedding gown. Yeah, you wanna do right, but not right now. Oh me, oh my, oh, would you look at Miss Ohio? She's running around with a rag top down.
'cause I wanna do right, but not right now.
Wonderful. I want to thank you, Doug, again, and thank you to all the Jerry Pal listeners. We look forward to talking to you next week. Bye.